about posterior shoulder instability today. Posterior shoulder instability is a spectrum of disease which can result from a subtle, very minor micro instability to a frank locked posterior dislocation. So posterior shoulder instability is a spectrum of illness. If we see the glenoid here, this is the superior labrum, and the superior labrum of the biceps, the slab region, as we all know, extend posteriorly into the posterior labral tissue, and this tissue can be injured by a direct blow to the anterior shoulder. So if anybody is standing here and if you should make a direct blow to the shoulder, this can lead to a posterior subluxation or injury to the posterior labrum. This is very common in contact sports like kabaddi and rugby. This is also very common in India in sports, in cricket players. Typically batsmen, when they play shots, so when they play the shots, there is a load on the posterior labrum. So this posterior labral injury can be a direct contact sports injury, and this will give more of a pain picture than the instability picture of anterior shoulder instability. So this will not cause a recurrent shoulder dislocation, but this will cause pain which is localized into the posterior aspect. And if you do some sort of a posterior thrust or you do a posterior draw of the shoulder, the patient may be painful. Sometimes you may not be able to elicit the test, but classically they will present with pain which is more than the instability per se. And these patients need to be evaluated with MRI, needs to be evaluated with if it is positive and if you are in a high suspicion, then you can go ahead with an arthroscopy and you can repair the labrum. The important thing is, if you are repairing the posterior labrum, you may need to have 2 or 3 posterior working portals. That is number 1. You have to operate with the anterior superior portal anteriorly, and you might use a push lock anchor on the anterior aspect of the superior labrum. On the topmost aspect of the biceps, you might need a anchor which is knotless, because it will not abrade on the labrum or on the cuff. So on the superior most part you can use a knotless anchor. Rest of this you can use a regular anchor or a knotless anchor. The other important thing is, those patients who are having osteoarthritis or who are developing degeneration of the shoulder will also develop posterior labral injury first, and most cases of osteoarthritis and rheumatoid arthritis, you will have wear which is more posterior. So posterior wear is usually a result of osteoarthritis. Initially early osteoarthritis or early sort of an arthritis, you will have starting of the posterior wear, and that may also start with the posterior labrum. So this can also be a start of degenerative process in the native. Now occasionally the patient has got a high velocity injury, specifically in 2 conditions: seizures and electric shock, where the patient has got a high intensity trauma to the shoulder and the shoulder dislocates posteriorly. Now posterior dislocation of the shoulder is very commonly missed, because if you see an X-ray it may look normal. There is a sign which is called as a light bulb sign. So if you see the AP X-ray, it will be a light bulb sign, and occasionally it may be missed on the primary X-ray. And if it is missed on the primary X-ray, they may present to you late, and this presentation is called as a locked posterior dislocation of the shoulder. So these patients may present to you after 2 weeks, 6 weeks, 10 weeks, 3 months, 6 months, and this is called as a locked posterior dislocation. In a locked posterior dislocation, you will have a RHS phenomenon, that is called as a reverse Hill-Sachs lesion. So this reverse Hill-Sachs lesion is on the anterior part of the shoulder as compared on the humerus as compared to the posterior part. So this is an anterior part. This is called as a reverse Hill-Sachs lesion. There is a dent here. This is called as a reverse Hill-Sachs lesion. That is number 1. And these are very difficult to reduce. So this is a dent here, and from dent there is a lesser tuberosity here. So it is just anterior to the lesser tuberosity. So if a patient presents to you with a locked posterior dislocation, the ideal procedure which is recommended is called as a modified McLaughlin procedure. in which you approach the shoulder with a deltopectoral approach. You do a LT osteotomy, LTO, that is the lesser tuberosity osteotomy. And the osteotomy that you do for the lesser tuberosity, you fix it into the reverse heel sex. So you do an osteotomy of the lesser tuberosity. The lesser tuberosity fragment you medialize into the reverse heel sex to make it stable. Okay, so LT osteotomy and fixation of the LT osteotomy into the reverse heel sex lesion is called as a modified McLaughlin procedure. The original procedure described includes use of a screw fixation, but nowadays we do this osteotomy fixation with anchors, usually in a double row fashion. So as we all know, we do tape lock technique. So we put two tape lock anchors on the middle part of the reverse heel sex and two anchors, knotless anchors, on the lateral part of the reverse heel sex. So this log posterior dislocation is approached with a deltopectoral approach, lesser tuberosity osteotomy, reduction maneuvers of the joint. We need to reduce the log posterior dislocation, and then the LT osteotomy is reduced into the reverse heel sex, medializing the osteotomy fragment. Okay? Any questions so far? Okay? So this is regarding the posterior shoulder instability and posterior shoulder dislocation.